Thank you, everyone. Today we have an exciting session planned. Before we get underway, I just wanted to make a couple of notes about today's webinar session. We will be recording a webinar, and that will be made available after today's session. As a result, we're going to be muting all of the lines. This will help with the quality of the recording, the background noise to a minimum. So you will be muted. If you have any questions, please use the chat window at the bottom right-hand portion of your WebEx screen. We'll be taking some questions at the end of the session. If you have questions throughout, please enter them into the chat window, and we'll take note of that and try to get to as many questions as we can at the end of the session. We are expecting probably a little more than 30 minutes today, probably closer actually to 4 minutes, with about 10 minutes of questions. And just a reminder, VisualSonics.com/webinars, please visit the site and continue to join us for these sessions on an ongoing basis. I'd like to introduce our guest speaker. This is Professor Brent French. He's a professor of biomedical engineering at the University of Virginia at Charlottesville. And Dr. will be speaking to us today about geography with the Vivo 2100, applications in mouse models of myocardial infarction, and LV remodeling. Dr. French is a longtime friend and user of VisualSonics technology, and it's really a pleasure to have him join us today online from Charlottesville. So at this point, we're going to just pass the presenting rights over to Dr. French, and we'll get underway. Dr. French, are you there?
I am. Thank you, Drew. And I'd like to thank everyone for tuning in. It's not often we get to reach such a wide audience in such a specialized topic. So without further ado, I'll get started with applications in mouse models of myocardial infarction and LV remodeling. As most of you must know already, mouse models of infarction are valuable for looking at gene function and transgenic and knockout mice in genetically manipulated mice, as well as I'll show today, and also touch upon the testing of new therapies for myocardial infarction and LV remodeling. Furthermore, the mouse model is useful for developing new diagnostic indices of heart disease, and I hope to show a few examples of that as well. And we all appreciate that performing imaging in mice is quite challenging. It can be difficult to quantify subtle functional differences in mice due to the small heart size and the rapid heart rate. The example I'll cover today is a study in which we evaluated the efficacy of ECSOD gene therapy in a mouse model of post-MI LV remodeling. And of course, ECSOD is the extracellular isoform of the superoxide dismutase enzyme. So, introduction, again, this audience, I'm sure you're quite familiar with the progression of LV remodeling as a result of myocardial infarction. Here we've got a diagram from a review paper in which we depict the infarct zone. Let's see if I can get my left pointer working here. We depict the zone, we show acute compensation, and one thing that's not really appreciated but has become evident with the advent of cardiac MRI and late gadolinium enhanced imaging is that the cut point between stabilization and LV remodeling, at least in humans treated with inhibition and beta blockade, is about 24% of LV mass. So if infarct is less than 24% of LV mass, you're likely to stabilize. Whereas if your infarct is much larger, the additional wall stress that is imposed upon the rest of the heart, particularly the LV, is predisposing you to LV remodeling and ultimately failure. So it's this balance that we're looking at in the study with the hypothesis that we can move that balance point with gene therapy. So, by way of introduction with regard to the gene therapy vector, this is adeno-associated virus. I won't go into a great deal of detail since our focus really here is on ultrasound and not gene therapy, but there are some key advantages to adeno-associated viruses as a vector system that we've listed here. And the thing that I'd like to point out in particular is the serotype of AAV that we're using, the AAV9 capsid, which is already cardiotropic, but which it has preference for infecting cardiomyocytes naturally, actually muscle tissue in general. But this can be made even more specific by utilizing a cardiac-specific promoter. So this is bioluminescence imaging shown at the right, where we have the CMV promoter, drive luciferase, and so in essence, this mouse from head to tail is glowing like a firefly after luciferin injection, where the cardiac-specific promoter and a single intravenous injection of a reasonably small dose, we can get cardiac-specific gene expression. And if we switch reporters to GFP, we can prove to you that at reasonable doses, we're not just hitting every cardiomyocyte in the LV, we're hitting the cardiomyocytes multiple times over. So these extra white cells represent cells which are expressing 5 to 10 copies of GFP. So this is a pretty powerful system to use test bed for various testing various therapies against LV remodeling. And so the hypotheses here were first that we could inhibit LV remodeling with cardiac-specific expression of VCSOD, and that secondly, higher resolution echo could provide sensitive measures of the effects of gene therapy on LV form and function after MI. A few words about the experimental design. These were male C57 black 6 mice, aged 10 to 12 weeks at the beginning of the study. We used a jugular vein injection under anesthesia to make sure that we got all the viral vector in. Sometimes vein injections are a little less reliable. We used 1 times 10 to the 11th vector particles per mouse, and we administered them 10 minutes after reperfusion. In the study, since it is an LV remodeling study, we used an extended coronary occlusion, that is 60 minutes, and that's perfectly to get a large and reproducible myocardial infarct. We typically look for infarcts that involve 30 to 50% of LV mass, so that we're well above that 24% cut point. And we applied the Vivo 2100 to do high-res echo at the following time points after reperfusion, that is 3, 7, 14, 21, 28 days. And of course, most of you are quite familiar with the Vivo 2100. In particular, we're showing here the most mount for the transducer and the platform, along with a micro manipulator by which you can step that platform as well. Got a rendition of it here stylistically of the most transducer, skin heart, and in this study we took 12 parallel short-axis slices, and we stepped them at 0.5 milliliter intervals. And so this is high imaging, and we're doing this in a very MR analysis. We're taking a dense axis stack and doing image analysis on every slice. And we've done that in essence because we've invested so much in the mice at this point in time that it only makes sense to spend an equal amount of effort on the analysis. So by Simpson's disk volume sum n, we can figure out our LV volumes as well as our the volume of the muscle mass. All right, and we also made use of the VivoStrain package on the 2100, and that's shown here, where where at left you've got normal synchronized wall motion from a standard mouse, and at right we're reminding you of the different strain measurements that can be made in longitudinal strain, in blue circumferential strain, and in green real strain. I'll see if we can get some of these cines running now. So at baseline, we are showing a normal mass here and normal contractile function. This is a long axis image, of course. Day 3, it's after MI. It's easy to appreciate the infarct in the anterior wall. Day 7, this chamber volume has increased substantially. The wall has dilated in the infarct zone, and by day 18, and as we've shown in previous studies, this is essentially nearing the end of LV remodeling. So you've got about as much chamber volume as you're going to get, and one would not have any trouble distinguishing between this heart at day 14 and a normal one at baseline. So let's do controls and ECSOD treated. This is at the end of the study, day 28. You'll notice substantial LV remodeling. We've assumed a round geometry as opposed to an oval, and that's a bit improved with the ECSOD treatment. So again, using the disk sum method, we can accurately determine the LV volumes, both at end diastole and in systole. Interestingly, there is not a lot of difference between groups up to day 7, and that difference only becomes apparent at day 14 and is maintained until day 28, both in the end diastolic volume and in the end systolic volume. So because changes are proportional, then there's really nothing to be seen from ejection fraction. And I think this is an important point, that if one just stops the analysis at ejection fraction, they may miss quite a bit. Of course, you need within systolic and diastolic volumes to get ejection fraction, but it shows the importance and actually why we favor, as a single endpoint, we would favor end systolic volume over any volume when it comes to LV remodeling studies or any other global metric, I should say. Turn now to even a higher level of analysis, which is in the speckle tracking, and we'll look at the specking output of VivoStrain in a normal mouse here. And if we look at longitudinal strain, we'll see that in each of the segments it's highly homogeneous and behaving like a normal mouse should. Look at day 28 after MI in control mice, and again we've got a basketball-shaped heart. We've got variable one in the infarct zone, and basically this mouse is living off of its basal aspect of the heart. To the ECSOD, and you'll see that the extent of the deficit, wall motion deficit, is much smaller, and that we're getting better strain generation throughout the posterior wall. So we can sector this up and look at individual sectors by longitudinal strain. As you notice here, we've only really got one segment which is behaving normally, and the rest of the segments are severely defective. CSOD, we've got more segments that are contributing to longitudinal strain. So then put numbers on all that, and each of the mice in the group, which ranged from eight or nine mice per group, will find that we really only have a difference, statistical significance in longitudinal strain in the basal inferior segment and in the basal anterior segment. So most of the improvement is actually manifest in the basal aspect of the heart. But that improvement is good enough to give an overall significant improvement in global longitudinal strain. Why did we focus on longitudinal strain for this study? The short answer is we were trying to finish up the study before the AHA abstracts became due, and longitudinal strain is from a long axis image, gives one probably the best assessment of the overall extent of injury, certainly than any single short axis plane, because any single short axis plane will not give you as good an overview as a long axis will. But also regional LV geometry and the radius of curvature, which is larger in the longitudinal direction, at least in the ECSOD treated mice. And so the longitudinal strain may actually be a more sensitive measure of cardiac dysfunction, at least in this study. So with this study, cardiac specific expression of ECSOD attenuates LV remodeling. The serial studies of LV remodeling are expedited using high-res echo, and speckle tracking with the Vivo strain on the 2100 provides the spatial and temporal resolution necessary to detect subtle differences in regional cardiac function, which are not as evident from global measures such as EF. Remember, in EF we saw essentially no difference between groups. So now to the subject of non-invasively measuring infarct size in mice. And in this study, we've got the advantage of having a high-field MRI scanner available to us, and many years of experience in using late gadolinium enhanced imaging to accurately measure infarct size in mice. And we published that back in 2004. We showed that infarct is determined by gadolinium enhancement by cardiac MRI is very tightly correlated with infarct size as defined by the standard histological assessment by TTC. Many years, cardiologists have been eyeballing the presence or absence of infarct in patients using echo just looking for wall motion deficits. And so it makes sense intuitively that one should be able to use radial strain as a measurement of infarct size. And if we code these high density stacks of short-axis images for cardiac function, radial strain by the VO 2100 versus late gadolinium enhancement by MRI, you can see that there is a spatial correlation. So we wanted to try and put a number on this and make this a little bit more quantitative. Again, we do have the advantage of having state-of-the-art instrumentation, both with regard to the VIVO 2100 and with regard to high-field MRI. And 7 Tesla ClinScan, which is represents a collaboration between Brooker and Siemens. It's not everyone has these resources available to them, and so what we're hoping to do is to make the advantages of high-field MRI to transpose them, so to speak, onto output from the 2100. So in this, again, we're looking at a 60-minute core inclusion in B6 mice. We're using the 2100 with the MS400 transducer, again, high-density short-axis stacks, and comparing that against late gadolinium-enhanced imaging using inversion recovery to detect the T1 shortening by the gadolinium contrast agent, and again, using that same short-axis stack taken at 0.5 millimeter increments. There are a few examples. We have indicated the infarct is detected by the gadolinium is brighter too, and one can see that quite evident on the top row. On the second row, we have a map of radial strain as determined with the 2100, and you can see that radial strain, of course, is better in red in the viable tissue, and there's little or no strain in the infarct regions. So what we did was to apply a receiver operator characteristic analysis, an ROC analysis data, and basically what we're trying to do here is to determine the threshold at which the radial strain detects the presence of infarction. And so basically we tested various thresholds and got best area under the curve here at a radial strain threshold of 16%. So here's the curve, fairly good on the true positives and true negatives. The sensitivity, 0.86, specificity, pretty hard to beat, 0.94. If we look at infarct size using this 16% threshold, we look at infarct size by ultrasound, compare it to MRI, that's not a bad correlation, R squared of 0.01, and the bland Altman is pretty level too. So this is a reasonable way to go about detecting or measuring infarct size in mice, and we've got a few to illustrate that. So we've got a spinning heart showing you the area that's enhanced by late gadolinium. And this is really an apples to oranges comparison. The late gadolinium is essentially measuring the same thing as TTC staining, whereas radial strain, of course, is measuring just that. And you see that the area that's afflicted in the anterior apex of the heart is very similar between the two. If we take and we make predictions out of those stacks and flatten it out like a world map, you can see that the locations of Africa are similar between the two. And of course, that threshold of 16% rate of gain is what enabled us to generate that map. So we've got a couple of additional cities to show you here in a normal mouse. This is using an analysis, the post-hoc analysis, to see circulation through the wall throughout the cardiac cycle. And here, 28 days post-MI, I wanted to show this particular cine because it illustrates the cardiac desynchrony that can develop late after MI. That there's almost a peristaltic wave that's of strain generation in the posterior wall, and that actually the action is headed in the wrong direction. So that's not very good for cardiac output. So the final topic I'd like to touch upon today is measuring LV desynchrony with the VO 2100, and in this we've used 11 control mice, and we've used 9 INOS knockout mice. And the study design is the time is depicted at the top, where we've got baseline imaging, we've got ischemia reperfusion injury at day 0, and then imaging at day 2, day 4, day 7, day 14, and day 28. And this, I guess, is our preferred timeline for catching as much as we can out of the progression LV remodeling. And I'll show you in a moment the utility of the day 2 and the day 4 measurements. Let's look at systolic and diastolic volumes over time after MI in normal and INOS knockout mice. Now, our lab and others have previously shown that remodeling is much reduced in INOS knockout mice. So that's already been shown, but in this study, we wanted to use the VIVO 2100 to try and more accurately assess what was actually happening in the heart with a higher time points and at higher temporal resolution at each one of those time points. You'll notice that when it comes to either end-diastolic or systolic volume, there's not a lot of difference between groups up to day 4, but then we get divergence at day 7. In fact, we get statistical difference from 7 on to the end of the study. And remember, I said that in most cases, you'll get most of your LV remodeling complete by day 14. The utility 28 is to prove that the effect is durable. And for instance, in the INOS knockout mice here, shown in red, they maintained that advantage out to day 28. It was not a transient improvement. So these differences were big enough that, yes, we did wind up with statistical differences in ejection fraction in this case. So we reached the significance at 14. It was maintained at day 28. But what we really wanted to talk about here was cardiac desynchrony. So one form of cardiac desynchrony is the dyskinesia or paradoxical wall thinning that occurs early after myocardial infarction during the process of infarct wound healing. And so in pilot studies, we determined where that was maximal, and it's somewhere between 2 and 3 days post-MI. And we've also, in this article here, published in UMB and last year, characterized a new metric for measuring measuring that LV dyskinesia. We call it the Contraction Index, and I may be running out of time to get to the details of how it's calculated, but basically it's using equations very similar to those used in AC power output. It's measuring efficiency. And so, for instance, if we look at 3 segments, let's imagine a single short axis slice, and we measure displacement in each of 3 segments rather than 6, simply for the case of simplification. We'll see in a normal mouse that we get pretty good displacement no matter where we look. If we then add up the sum of those displacements, we get the curve in green. And that's fine in a normal mouse, and the area under that curve we'll call the contraction index. Imagine that we've got a post-M mouse that's even got some paradoxical wall thinning, some dyskinesia in the infarct zone. Well, in this mouse, we'll actually, if we take the unsigned sum, we will get a different value than the signed sum. So if we take absolute values, is what we mean by signed sum. If we take absolute values, we get a bigger the curve than if we take the unsigned sum. So that's what gives rise to the weighting of the contraction index. It's specifically weighted in order to be sensitive to dyskinesia. And in that paper, we compared this new metric against a variety of existing metrics, and you can see that the contraction index in green is quite sensitive to the dysfunction that occurs shortly after MI, days 2 to 3. Post-MI, and that it's not very sensitive to the dysynchrony that occurs later. Other metrics, such as standard deviation to time to peak strain, are actually preferred for measuring the form of LV dysynchrony that forms in the viable myocardium later after MI. Turn back, let's apply that metric now in this particular study. Let's apply the contraction index and look at LV dyskinesia, focusing particularly on day 4. Now, we recommend picking up that time point because it's an excellent place to apply this threshold of 16% radial strain in order to determine infarct size and to demonstrate that your infarct size is similar between groups. It's preferable to day 1 because the mice are fairly unstable at day 1, and their respiration is much improved on day 2, if not the ECG. So we've transitioned from first scan after MI being at day 1 to using day 2. The reason why we like day 4 is because it's particularly sensitive here to the dyskinesia, LV dyskinesia, and you'll notice with contraction index on the right, we've got a statistical difference at day 4 in the contraction index, and at a point where there's essentially no difference in the LV volumes. Those differences don't show up until day 7 or later. And so I can argue here that the contraction index can predict subsequent LV remodeling. Now to the form of dysynchrony that develops in the viable myocardium later after MI, and we've previously used or preferred standard deviation of time to peak strain for that measurement, but here we've applied a new method which is related to RUR, to radial uniformity ratio estimate. and that's where we're always using a Fourier transform, but the input data into that Fourier transform is radial displacement instead of radial strain. So this simplifies the analysis a little bit, saves a step, and we think gives results that are comparable, perhaps even better. We still have to figure that out, but in that we are, with this metric, we're detecting a difference between groups at day 4, and that is maintained out through the end of the study. So this would be a potentially useful metric for long-term dysynchrony. So I thought it would be good here to finish up to acknowledge my many contributors for these studies, primarily John Hossack, Fred Epstein. We've got some postdocs in the lab, as well as graduate students that contributed to the study, and we've also got grant support from the NIH and from the HA. So I think we'll turn it back now to Andrew to field some questions.
Thanks very much, Dr. French. That was fantastic, and we do have some questions coming in. So I'm going to start it. One here from memory. Okay. Do you have any suggestions for performing echo on post-MI mice when maneuvering around things like sutures, tissue adhesion, etc.?
So that's an excellent question, and our preferred method is to actually change the surgery a little bit, change the access point so that you avoid the region of the chest that you're ultimately going to want to perform echo on. So we've taken to moving our incision down to the side to the extent possible that we can still access the anterior wall while impact on the area that is where you're going to apply the transducer. There are also post-processing approaches that Dr. Hossack is developing, and these involve principal component analysis to essentially denoise the images and try and re-extract the data that is being essentially showed by those artifacts. And so he has an EEE paper. If you look for Dr. John A. Hossack and IEEE, you can find his description of that approach to post-processing and getting the maximum you can out of your images.
Okay, you had that citation, so I can certainly send that along to this listener. Actually, just a follow-up question from the same listener. Just look more at your great suggestions. Do you have any suggestions on maintaining an adequate heart rate on a post-mouse during imaging while it's under isoflurane?
So that is going to be improved on day 2 versus day 1. That's one of the reasons that we've decided to move that time point back a little bit. There's a distinction, I guess, between the intrinsic heart rate and whether or not you're having troubles picking up the ECG signal, right? We have found that heart rate does increase slightly after MI, but I would suspect that what we're really talking about here is having trouble picking up the ECG, because the heart rate is pretty regular. It is increased some. One can compensate for that by cooling the mouse down a little bit, but that, of course, impacts your cardiac function.
Right.
So we're religious about keeping our mice at 37 degrees and documenting that with the thermoprobe.
Okay, that's a good tip. Just for, here, they're trying to get a sense, I think, of what is the best measurement method to evaluate heart function and infarct size post-MI at multiple time points. And the question is really about 2D imaging versus 3D imaging, and what are your thoughts on that? It seems that this group is using 2D, but they've been hearing more and more about 3D, and wondering about your opinions on the differences.
So this could be another 1-hour webinar to try and do this series of questions justice, because I'll address the 2D versus 3D first to try and understand what is meant by that, because of course we do have true 3D transducers for mice, although those are available clinically for larger animals, and it is pretty convenient to have a 3D phase array transducer for generating LV volumes. But even those centers that have them tend to use 2D, because 2D slices are of higher resolution. You give up a little bit in acquiring those volumetric slabs all at a single time. So I think that what the question refers to is can you simplify, or can you expert your studies by undersampling either in the long axis or in your short axis stack? Is there a minimum number of image planes that you can interrogate and still get essentially the same data? And that becomes a question of one of image acquisition versus image processing. And this can vary between laboratories. For instance, in some centers, it might cost $120 an hour to access Vivo 2100. There might be a early rate. You might have to get you may do your imaging studies as quickly as possible. But I might point out that with the motorized stage and with the right programming, one could essentially get a 0.5 millimeter incremental stack at essentially the same period of time that you would spend getting a conventional B mode. Further stack B mode images. So is always, analysis is always 3D in the sense that we are taking the summation of stacks. And the question boils down to how many acquisitions are you going to take, and how much time can you invest in the image processing, and those can depend on variables that are different between centers.
Yeah, and I just on that point, I want to go to another question because I think it ties in really about how the measurements were done with system versus what you had done, and the question is really about the rate strain calculations, whether they're included with the Vivo strain software or whether they were in-house. So just to make that clarification, for the two-dimensional images you see, that is done with the Vivo strain software. However, the reconstruction of those 3D sets was done with the group at UVA by basically taking those values and then using an in-house program to show that. So am I correct in how I summarized that, Dr. French?
Right. Thank you. Thank you very much for making that distinction. So I showed earlier on, let's see if I can zip back to it here, some of the output from vivo strain. So this is all vivo strain, and of course these very impressive are all direct outputs of vivo strain. But what you can also get out of vivo strain are Excel files that give you each of the values, displacement values, strain values in each of the 36 segments. And those Excel files, we input those into MATLAB programs. And so some of these other these, particularly with regard to cardiac desynchrony, for instance, the contraction index, the desynchrony index, those are derived by taking those Excel raw data from VivoStrain and inputting them into MATLAB routines. And we're working towards making those available to the public. I think the first thing that we try and make available are the conventional measures, such as the temporal uniform strain and standard deviation of time to peak strain, so that using strain could run these MATLAB programs and get these metrics directly from their data.
Okay. Yeah, I would say has more questions on the specifics of the software package that we offer and the data that it outputs. You can certainly email us info@VisualSonics. I think we're going to put my personal email up as well, which is emails@visualsonics.com.
I might add that if there is interest in that, people should go ahead and let you know about it, because how are we going to know otherwise?
Yeah, exactly. That would be great feedback. Just another question here about Infarct Size, the actual Infarct Size itself, and whether you looked at that with TTC, also with MRI and ultrasound.
So in various studies, we have not yet performed the ultimate study. So previously in circulation, we validated the MRI technique against TTC. And in that study, we used the MRI as the gold standard. That's, I guess, defensible in the sense that the late gadolinium enhancement is now, considered, at least at the clinical level, the gold standard with regard to infarct sizing. So in cert validations, yes, we've confirmed it with TTC. It would have been preferable to have done the TTC in this study as well. I don't have that data to share with you today, but since we previously validated it, we have every reason to believe that it's true. I guess in follow-up to that question, I might add that this radial strain at 6%, this cutoff determined in this study, is good for our mice at this age under these conditions. And if you were to really do this rigorously at your own institution, what you'd probably want to do is repeat the radial strain measurements, use the mice, perform the TTC analysis, and do your own RE analysis, because you might find that in your hands the strain threshold is 14% or 18%. But the overall experimental approach is valid.
For a few minutes, there's some questions more on the methods that you use. Listeners are just wondering how long to do these types of experiments with some of the strain data that you showed. How long is that scan? How long is the animal under anesthetic for?
So we typically these studies, perform them from knocking the mouse down to putting them back in the cage in 40 minutes. We get a little uncomfortable leaving mice under for more than an hour, especially after MI. These are not unduly, the actions don't really take that long. I might add that the motor stage is more convenient. You also have the stage upon which the mouse sits has a micrometer built into it, and if one aligns the mouse properly on that stage, you can use that micrometer to advance the stage in half-millimeter increments, and you can achieve the same short-axis stack, just the same you would in MRI.
Okay. Yeah, that makes sense. Question on the transducers. Someone specifically about the two different transducers that VisualSonics offers, the MS400 and the MS550. I actually apologize, I can't remember on your slide if it said which transducer you were using.
Right, we've got the 400.
Okay, so I guess the question is, certainly the 400 has a deeper penetration than the 550, which would have superior resolution. Was there any particular reason why the choice of transducer?
It was the impression that the 400 was the preferred cardiac transducer. I think that we do have a 500. I don't know that we performed a rigorous side-by-side analysis, but I think that our ability to see the posterior wall was adequate with the 500.
It certainly depends on the model as well. Some of these MI models, it can be more challenging, and the 400 definitely just give the better image quality that you need. It's certainly as you go deeper, as you say, on the posterior wall. 550 can be used as well, and we've seen groups do that. So I guess there's no clear-cut answer to this based on our experience. It really does depend a lot on the model that you're looking at. And I guess it's interesting to hear that for your particular case, the 400 is working well. So that's good information. I'm going to ask the last question here. I think we've got all of them. If we do apologize ahead of time, we'll check at the end. If there's any we've missed, we'll certainly try to get that answered with Dr. French's help. I'm just reading one here as it comes in. Will the ejection fraction percent measurement be done better on a parasternal long axis B mode or parasternal short axis M mode? This participant is finding this variation. I wonder if any experience, Dr. French, with these two types of measurements.
So we rarely use the M mode because we prefer to have that to be able to assemble a 3D reconstruction of the heart. Our concern with M mode is that it's undersampling to to a very great extent, and so it will be entirely dependent upon what line querying, whether you're inside an infarct or outside the infarct, and without knowing where you are relative to the infarct, you could be deceiving yourself.
Right. Okay. I think on that note, as I mentioned, I hope we've got most of the questions. I don't think we've gotten to all of them, but Dr. French, I know you're going to have to run to get to a lecture, so I don't want to keep you too much longer. I'd also like to try to keep within the time frame that we had set aside for people, because I know everyone's got busy schedules and busy days. So I would like to thank you on behalf of the audience and everyone here at VisualSonics, Dr. French, for joining us today. It was an excellent talk, some great questions from the audience. It's always interesting to hear the types of issues, challenges, questions, and queries that people have. So thanks for sending those in, and we will go on and follow up with any that we weren't able to get to. Just a couple of reminders before we sign off. Again, there's a recording going to be made available of today's session, so So you will have that. You can see and look at it at your own time if there's anything you'd like to review. There's also a survey included in this email that we'll send out. If you do have some time, we would love to hear your feedback on the session, any feedback about future sessions or the VisualSonics products in general. And one last reminder about AHA, we will be hosting a customer event at AHA. We'll also be at booth number 301. So please visit our website for information on the customer event. This is a with dinner. We will also be joined coincidentally by Dr. French, who will be presenting, along with Dr. Wolfram Zimmerman from We'll have some scientific sessions and the opportunity to speak with our speaker and other members of VisualSonics staff and other attendees that are present. So please register for the event, this dinner event at the conference. Last reminder is the future webinars that will be coming up. We have in December a session with one of our application specialists scheduled to talk about microbubble contrast imaging. So please join us for that. And please check the website regularly for upcoming web sessions in the new year. So again, thank you to everyone for joining. Thank you to Dr. French. It was great to be on the line today.
It's been a pleasure. Thank you, Andrew.
Okay. See everyone soon and enjoy